Hello, everybody. Welcome to our weekly Zoom chat webinar hosted by the neurovascular team at Lenox Hill Neurosurgery. And please enter any questions that you have through the chat option. That way we can answer live. And while we wait for some people to send us some questions, we can start talking about the current state of what's happening with COVID in the hospital, the city, the state, and the country and the world. I know that there was a paper that came out today that demonstrated that hydroxychloroquine is not effective for treatment of these patients. Were you able to look at this, Dr. Ellis, Dr. Langer? Or not yet?
Yeah, I mean, I think it's a retrospective paper in the VA system.
Yeah.
No control group, and it's decent data. It's not but we're never going to see a randomized. I talked to some of the military guys today. They're like, "Yo, they never did a randomized trial of parachutes either." It's like, I think that it's going to be hard. Sometimes these kind of like dogma medical decisions, as long as they're not killing people, they're kind of hard to break, especially in a brand new disease. Although the problem here is that in that study, it did show a higher mortality rate with hydrochloroquine alone. So,
yep.
I think I personally, if I had COVID, wouldn't give it. But, trust me, I mean, it's going to take time for this sort of bake in and be an acceptable strategy. I do think, and I think that after talking to John, that I think this Pepsid thing is likely to be favorable. And this whole time right now is basically looking at therapies and therapeutic development and sort of cycling through these different drugs, because undoubtedly we're going to have hopefully drug therapies that work way before we have a vaccine. And so having an aggressive therapeutic clinical trial strategy, but it needs to be done very stringently, so the data people are going to. There's all sorts of bias unless it's really done well. There's always an argument against it. So we'll see. I think it's such an exciting time. It's a brand new disease, brand new ideas, pretty cool stuff.
Yeah, we're learning something new every day.
Yeah, for sure.
It's crazy. Like people have been out of medical school, some people for 20, 30, 40 years, and they had never heard of anything like this, and learning on the fly. In that paper, the mortality with hydroxychloroquine was 27% versus 11% of people that did not get the drug. So obviously it was significant. Now people are thinking that maybe the other drug, remdesivir, the antiviral drug, might have a better outcome. And
that's interesting, Rafa, because Plaquenil or hydroxychloroquine is a staple in the ICU for COVID patients who have increasing inflammatory markers and aren't doing so well. So the fact that this information is coming out now, that it may not be as effective as we thought, could represent a very dramatic change in clinical practice. It's in heavy use right now. So that's interesting data that we have to take into account.
The other paper I think that I just read that Scott Gottlieb put up on Twitter was basically even more interesting. It's not a therapeutic study, but a diagnostics based on testing, where there's a town called VO apostrophe. It's in the Veneto, in the Lombardy region, which is where the center of the Italian epidemic was. And what it showed, they basically studied the population of VO, like 8,000 people, the day the virus was tracked, and then 2 weeks later. Basically about 8,000 the first time, like 7,500 the second time. And what they showed was at the first time, there was about only a little over a 2% infection rate in the population. This question is how infectious is this, and all these asymptomatic cases. Maybe the infection rate's 40% of the population. Who knows? It was only 2%. And then at 2 weeks later, when they, after quarantining and separating the people out, the infection rate was 1.8%. So quarantining works. In other words, the infection rate stayed low with social distancing. But there were two other amazing things. 46% of the patients that were positive were asymptomatic. 46%, which is like crazy. And there was not a single child under 18 that had viral titers, not a single one. And in fact, people who converted at the 2 weeks, they had 8 patients that were negative during the first study and were positive at the second one. They were all living with COVID positive partners or whatever. None of the children in those households became positive. So something really unique about being a child with this disease. And I think it speaks to some of the questions about opening schools and the teachers, and are children vectors but are not carriers? So I think it's really, what's so interesting is we're kind of in the middle of this kind of, world history, but we're experiencing in real time, and with the internet and with social media and stuff like this, such a rapid, dissemination of new understanding. And, I just called the guys at Javits today and told them to start everybody on Pepsid.
Yeah.
So, it's really interesting.
So other important things that are coming out these days and related more to what we do is specifically in patients that have suffered a stroke in the past. They have demonstrated to be at high risk of complications and death and mortality from COVID. And the actual number is 2.5 times the risk of developing severe disease or death if you have had a previous stroke. So these are obviously alarming numbers and important information for patients to know, for us to know as healthcare providers and taking care of them, and making significant strides toward preventing them from getting infected. Many of the concerns that people are having these days are, should I go to the hospital if I'm having stroke symptoms? Should I go to the hospital if I'm having chest pain? Should I just, and in many instances, many hospitals are not treating these patients. They have started protocols to avoid treatment of acute symptoms. We haven't done that at Lenox Hill Hospital. We have continued to take care of everyone with COVID and non-COVID. And we have done mechanical thrombectomy for acute stroke, coiling for cerebral aneurysm, stenting for narrowing of the artery in the neck, surgery for evacuation of hematoma or hemorrhage, surgery for a brain AVM, surgery for brain tumor, and even bypass surgery for patients that are non-COVID. Now, question that many people are going to have are we ready, and how are we going to be ready to start doing more elective cases? And are these patients safe? Is the healthcare provider population in the hospital safe? How can we prevent any of these people from getting infected? Any opinion on that, Dr. Ellis?
Well, there was a recent letter to the journal Neurosurgery about the mortality rate in patients who had subdural hematoma and COVID and underwent surgery for the subdural hematoma. And the rate of death was actually astounding. I think they had about an 80% death rate. And this came out of Italy. So I think we have to be careful in terms of doing procedures on patients with COVID. They're clearly at high risk for complications, and we can't just jump back into our usual, if there's blood in the head, take it out. We have to really consider the pathophysiology of this systemic inflammatory infectious condition. It's really affecting outcomes we're seeing.
It's possible, I think, you try to understand why that is the case, but I think that, there's a bias that amongst the intensivists, I'm sure Jason can comment on this too, that mechanical ventilation is actually bad in general for these patients. In fact, the reason why Lenox has such extraordinarily good outcomes is because they aggressively kept people off the ventilators early on. And if you think about it, one of the possibilities is that, especially in light of the surgical results, because everybody's mechanically ventilated, and even if you're just COVID positive, maybe it pushes some of the virus deeper into the lung, you're under positive pressure, maybe it causes more of a wide distribution of the viral load. You know, the cancer community was saying the same thing, that the cancer outcomes from surgery were bad if they were COVID positive. And maybe it's not the cancer, maybe it's the ventilator. You know, maybe it's the fact that you're putting these people on positive pressure in the setting of COVID. And I think it's probably more likely, especially when you hear people that are not immunocompromised necessarily, that are doing worse. And I agree, I think we're gonna have to we cannot do cases that are COVID positive at this point, unless they're, you know, pure emergencies, you don't have time but if you have time to test, theoretically that should wait until you have a test, at least unless they're dying in front of you. And I think this is a new world we're living in. We're going to learn pretty quickly if that's the right answer. And undoubtedly, there'll probably be patients that might wait and die. I mean, Jason had a case we were waiting on. It was because of COVID that ended up losing some vision. It's coming back now, but you know, we delayed these elective cases. But we're doctors. We're trying to balance all these different disparate interests and disparate factors and making decisions. And all we can do is, you know, do the best we can with the limited knowledge we have. But I agree with Jay. I think that we're not going to be able to do, you know, any case except the hyper emergencies without a COVID negative test.
Talking about weird doctors, there's a very interesting paradigm and way of thinking now that is very different from what the way we were trained and the way we've been practicing for years. Typically, we outweigh the risks and benefits of the disease in the patient and the treatment on the patient. Now, on top of that, we are outweighing the risk benefits of potential infection to us and the rest of the team in the hospital. And this is has to be taken into consideration and goes along with a question that we have on the chat that says, if my family member has a stroke and I bring them to the hospital, how do I know they are being kept safe? What is the hospital doing to ensure safety? Number one, in terms of answering this question, is we are in the hospital, we're taking every precaution possible to eliminate the risk of transmission. For example, people that are coming to the hospital, they are not coming with family members or other or friends or to the hospital. They are being taken care of by themselves. We are instituting ways to improve the communication between the healthcare providers and the family members so that people don't feel like they are in the dark and that they don't know what's happening with their loved one in the hospital. Having said that, it is too risky to have more people that aren't necessary in the hospital. That's one. Two, every patient that we're treating or that we're managing, we're checking for COVID, and we check multiple times. If they are COVID negative and they are going for a procedure, we check a second time just to make sure it wasn't a false negative. There have been reports of 20 to 30% possibility of a false negative in these tests. People that have the symptoms, even though the test was negative, we keep checking in a second, a third, a fourth time. We have a patient that we have checked 5 times in the ICU at Lenox that I'm aware of that keeps coming negative. However, symptoms are correlate with COVID. And so now that we're gonna start doing more and more elective procedures on people that are COVID negative, we are instituting policies in which we check the patients within 24 hours of surgery, just to make sure that it is safe for them to come to the hospital. The morning of the surgery, we will check them again. And we are instituting policies to check for antibodies for all the healthcare providers in the hospitals to make sure that everybody that is taking care of your loved one is not infected and safe to take care of that person. Anything else that you guys want to add?
No, I mean, I think that, you know, we'd all like to eradicate COVID from the hospital completely. The truth is, even if hospitals say they're COVID free, there's no way to prove that, you know, and it's nobody's COVID free, basically. What we can do is we're going to basically parcel out we concentrate all the known COVID positive patients and basically quarantine them within the hospital where the PPE and everything's maintained. But we have to treat every patient like they're COVID positive, you know, no matter what. You know, some of these issues with family members are going to come into play in the short term, whether, you know, how many visitors, maybe no visitors, like we said the last time in the last call. But long story short, the world's going to change. We're in a new normal and we have to adjust to it. And, you know, in the end, I think that as far as a stroke goes, if they have a stroke, they'll be treated just like every other patient, as expeditiously as possible to treat the clot and get the clot out, whether they have COVID or not. That's not a case that we're going to be checking for COVID. But what we will undoubtedly do, certainly if a patient has the findings of COVID, treat them as if they have it no matter what. If they have biohazard infiltrates in their X-ray and they got a fever, they're going to go to the COVID unit. If they're otherwise asymptomatically except for stroke, we'll test them. And if they're negative, they'll be in the non-COVID units, which we're going to work very hard to maintain. But there's really no way to avoid it. And anybody who tells you otherwise is not, it doesn't make sense. And we'll have to be all very careful. You know, obviously, I think we've taken the risks already. I think, you know, hopefully, I saw Sanjay Gupta last night got antibody tested, was negative, which sort of, so I would think all the healthcare workers that have been in hospitals, you know, for the last 3-4 months are probably all antibody positive. That's going to be interesting too when we test ourselves, which is coming. So it's a lot of interesting data points and a lot of decision making is going to go on over the next you know, few months for sure.
But obviously the real message for that original question of is it safe to bring the family member who's having a stroke to the hospital, the truth is it's definitely safer to bring that family member to the hospital to get the stroke treated than to have them die of a stroke at home. So you don't want to hesitate to treat stroke, okay?
Yeah, the World Stroke Organization came out with a statement earlier this week, specifically talking about this because they have seen a drop in stroke admissions throughout the world. They looked at 180 countries and the number of stroke admissions significantly lower than what it was before. One possibility is that people with TIAs or mini strokes or small strokes, they're staying at home and trying to avoid going to a hospital with the potential of getting infected with COVID in the hospital. So this is definitely a concern. Once someone has a mini stroke or TIA, even though the symptoms do get better, the likelihood of having a major stroke within a week is significantly higher. So people do need to be safer to go to the hospital and have medical attention in order to prevent a major stroke from happening. We still don't know what the effect of COVID is in terms of stroke. There's still a lot of anecdotes of hypercoagulability due to increased coagulation factors on the dimer, an inflammatory response of cytokine storm that could potentially increase the hypercoagulability of these people, or potential embolism coming from the heart, from cardiac injury, which is significant in the population that has severe infection with COVID. On the other hand, again, there are some other more environmental factors that could potentially decrease the risk of stroke. Pollution has decreased in many of the major metropolises around the world. There's less stress, staying at home and not having to deal with your boss all the time. And these are all variables that people, I'm sorry?
Depends who the boss in the house is.
Yeah. And these can obviously these are unanswered questions that will have some answers hopefully in the near future, given all the attention that we're paying to all these factors. In terms of, as a parenthesis here, in terms of mini strokes and people having stroke symptoms, again, we have an option for people to log in and get in contact with us through telehealth. We have two different options. One is through the Playback app, the Playback Health app, and the other one is through Lenox Hill Neurosurgeons.me, and I will enter this information now in the chat so that people can reach out to us if needed. Anything else, Dr. Ellis? I know we've been busy these days doing some of the typical cases that we perform in neurovascular surgery.
Yeah, what I have to say, just looking at the trends in the pathology coming in, we've certainly flattened the curve in terms of COVID, and with that, the typical pathology, like you said, we're seeing again in the ER, ruptured aneurysms, ruptured AVMs. Recently, over the last couple of days, have come in, and it's curious, where were those cases in the last 2 weeks? I would like to imagine that a patient with a ruptured aneurysm was not staying home, but we literally didn't see any of those things for 2 to 3 weeks, but now they're coming back now that the COVID curve is flattening. So that's an interesting phenomenon.
Okay. I think the cardiac, the people are seeing the same thing. The number of acute MIs is way down. And it's I don't know what it is. I mean, I can't believe it's all just from people not coming to hospitals. I think there's something more to this, and it's being seen. In fact, if you remember when the whole Javits Center was going to be built, it was to handle all the non-COVID sick patients that were going to not be able to get into hospitals, and no one showed up. There are no patients. That's why they turned it into a COVID unit over there. So I don't know what it is. I think I don't know if we're smart enough to figure out what's going to happen. There's an attempt at looking at number of deaths that they know what the number of COVID deaths are, and then they know what the average number of deaths in like New York City are at this time of year. And so there are these deaths that shouldn't be expected is what they'll look at. In other words, if there are 5 deaths a year, 5 deaths a month in the average March year, and now there are 10, but there's only 3 COVID deaths, and those 2 other deaths are something else. And that's the way they're going to ultimately probably parse this out. But I think the jury's out on what the cause of this is. It's certainly interesting. It's like a public health issue, and I think it's something that will probably come out with data in the next few months for sure.
Yeah.
Although we have all seen the reports of different paramedics being told not to take sudden cardiac arrest patients to hospitals. And that was as recent as last week because of the need of resources for patients with COVID. So on that same line, there yes, could be a trend on the field of people telling patients to stay at home and or trying to manage TIAs or mini strokes as an outpatient basis, which is a concern. But hopefully, as the curves continue to go down, hopefully we go back to a more normal, a new normal.
Yeah. And on that note, COVID has given us the opportunity to utilize some technologies which existed, but were very underutilized, such as telemedicine. And, I think once COVID is not as prominent, we will still retain the utilization of telehealth in a more robust way. So I think that's sort of one positive thing that has come out of COVID, it'll allow us to reach further and a more diverse population who may not be able to reach the clinics and the hospitals as easily. And we've seen that in our own practices, that we are reaching out to patients who may live in a different state, and we're reaching out to them in a very simple and technologically accessible way. So I think that's a good thing.
Last week, we spoke about the evidence of disparities depending on race and culture. And this has been seen throughout the world, specifically in the New York area. African Americans and Latinos had a higher incidence of severe COVID infection and mortality. And we were obviously giving our opinion and speculation on different reasons why this could be a reality. We spoke about many of them being the essential workers and being exposed more than others, the socioeconomic status of living in closer proximity and potentially having more infection risk. And this week there was another paper on the impact of nutrition on COVID-19 susceptibility and long-term consequences, and that it addresses specifically the disparities issue, and mentions about the importance of healthy diets and the negative impact of diets that are high in saturated fats, which are, we know that in underserved communities, it is a real problem for many reasons. Accessibility to fresh produce is lower than in more affluent neighborhoods, and education on this matter, as well as cultural aspects. Any opinion on this, Dr. Ellis, on how this could be directly impacting the outcome on these populations?
Well, on the ground, what I'm seeing is the biggest risk factors being advanced age, obesity, diabetes, and race. I mean, the reasons for race are multifactorial, as you have alluded to. But, you know, all the other comorbidities I mentioned, the diabetes, the obesity, the hypertension, all the things that go along with poor cardiovascular health are found to a higher degree in certain underserved populations. And I think that is not the only reason, but it's certainly a big reason why you're seeing some of these poor outcomes in certain populations.
I think it's also through access. I mean, I think that the minority populations tend to have higher concentration density, poor hospital, you know, don't have, I mean, look at Manhattan. We have like 5, within this 3 square mile area, we have, you know, these giant healthcare systems, and yet the population in Brooklyn near Elmhurst, which is really a community hospital, there's no big university hospital in Brooklyn. And, you know, the underserved are underserved for a reason. They're in the poor communities. The hospitals that are there don't have as talented of doctors. They don't have as much resource. They're not as big, and they got overwhelmed. So as much as I do think a lot of it has to do with their health to begin with, there's definitely a component of that. I think some of it's access and the ability to access good quality care right from the beginning. And some of it may be education, you know, that if they're not as educated, they may wait too long. Although, you know, at Jay's we saw a bunch of the Hasidic Jewish population got hammered, and really for the same reason. You know, they're very lack of social distancing, high population density, and poor access to care. You know, they waited it out. They all, you know, it's these in Corona Park and in Brooklyn where they go. You know, the Maimonides probably got overwhelmed, and so we were transferring a lot of these patients here. But long story short, I think, it's obvious. This is not surprising given we know this happens, whether it's childbirth mortality of both the mother and the child, the life expectancies, and then the outcomes from just straightforward things like cancer, MI, pneumonia. These are all worse in these communities. And I'd be shocked if COVID didn't work that way, to be honest, because nothing's changed. But I do think that this is because it's become a public health emergency. We hopefully will see some changes in the way hospitals behave, and it's obviously would be an ideal world, but we've let a lot of people down, and all aspects of society by our lack of attention to this.
And like Dr. Ellis mentioned, diet goes hand in hand with high blood pressure and diabetes. And many of these patients do have diabetes, the ones that present with severe presentations of COVID. And they are all medications that were protective or were thought to be protective in people with diabetes and hypertension, like angiotensin receptor blockers, ACE inhibitors. However, it has been noticed that these patients that are on these medications do worse in the intensive care unit while being on these medicines. Any observations like this, Dr. Langer, in the ACUs?
I can't say I've noticed, but one of the things that's coming out of this whole value of Pepsid. Did I say it at the beginning of this about Pepsid?
You mentioned, but can you expand on that?
Well, there's a Columbia, John just told me, there's a Columbia study that's going to come out looking at retrospectively that patients who are on Pepsid, and China did the same study, showed that patients did better if they were on famotidine. I think this may become the next chloroquine. John and I were just talking about that. And Lenox is actually spearheading a randomized trial using high dose famotidine. And John's really been the driver for that trial. I think we have the most patients enrolled, and it's a multi-center trial. We have the most patients enrolled, arguably all due to John and his team. So if I were you, I'd put my patients on Pepsid. That's for sure. I think that the trouble is the patients on these medications have the comorbidities, and there's no question. Look, all these comorbidities affect everything. If you do an aneurysm operation, people with obesity and diabetes do worse. I mean, it's just, they don't tolerate mechanical ventilation as much. They don't tolerate the stresses of an ICU. They already start with one hand tied behind their back in a boxing match. And when you have, anything that's going to affect multiple organs, the COVID affects the lungs, the kidneys, the liver, the brain, whenever you start off with a compromised, you may not be aware of it. These organs have a tremendous amount of capacity to tolerate a lot of crap. I mean, smokers aren't short of breath every day, but undoubtedly they're compromising a portion of the lungs. And smokers don't have as good of an outcome from COVID. So when COVID really stresses our entire body, all of our organs and our immune system. And so if you're compromised in any way, like these people are, they suffer more. And so some of this is due to, access, some of it's due to education, some of it's due to just, like you said, communities that don't have access to quality foods or cheap quality foods. This is nothing new. And this is just bringing these things out again and making it apparent one more way.
So this same study that looked at the angiotensin receptor blockers and ACE inhibitors, their explanation of why they do so poorly is because they do believe that there is you're causing a systemic vasoconstriction and increasing blood pressure at the same time as increasing sympathetic activity via central stimulation. That then leads to pulmonary capillary leakage, causing ARDS. So when we talk about central stimulation and sympathetic activity, obviously we're talking about the brain. And we're talking about the possibility of this virus directly affecting different regions of the brain. We have seen case reports of people demonstrating some hemorrhages or encephalitis, potential. We know that there could be loss of taste and smell, which is definitely some possibility of invasion into the brain. And we're definitely seeing pathological levels of neuroinflammation that could then lead to neurodegenerative conditions. So we're talking about a potential long-lasting effects that we might see months, years, decades from now due to this world pandemic. Any thoughts on this, Dr. Ellis?
Well, I think you're right. COVID, it's a primary lung disease, but it has systemic ramifications. We're seeing even in the patients that have recovered from the acute COVID pathologies that they still have issues, whether it be arthralgias. We're seeing patients who are saying they're having headaches, which they never had before. They're having issues with memory. So the real long-term consequences of a systemic inflammatory infection, such as COVID, are not yet documented, but we're starting to hear about it. And I think it's up to us at this point to start documenting these things so that we understand this disease better. And I think we're understanding that essentially every organ system of the body is affected by this.
Yep. Dr. Langer, any opinions?
I mean, well, part of the problem is when we got overwhelmed by this wave of cases, we just couldn't safely study people. We weren't doing lumbar punctures and moving people down to the magnets and getting CAT scans. Probably was we don't have a good therapy for any of this stuff. The COVID can cause encephalitis, encephalopathy from a toxic anoxic or sepsis, or just the cytotoxic storm probably makes the blood-brain barrier leaky and their brains swell. So you get patients that are encephalopathic that don't have encephalitis, and then you have encephalitis patients that are encephalopathic. And while differentiating those in an ideal world would be nice, because you could plasmapheresis or do something more aggressive, we just couldn't do it. We couldn't expose the ICU team to the patients because there's no good therapy. And we certainly aren't moving patients down to get MRIs and, moving a nurse and a PA and a respiratory tech and to the magnet and just exposing everybody with nothing really to do. So to Jason's point, I think we will learn more over time, because as the number of COVID patients drop, we'll be able to study them better and understand exactly what this disease looks like. But I mean, I saw a guy today that had a brachial plexus neuropathy, probably from proning, and maybe it was they're more susceptible because of, all the inflammation. We know patients that are chronically in ICUs have a higher incidence of peripheral neuropathy, for one. But I think there's probably, lots of stuff. The neurological manifestations, I think, ultimately will likely be kind of the final, finding. Everybody was surprised by the renal insufficiency and degree of renal failure, which really set us back. It was actually the dialysis machines, the dialysates, the actual fluids that are used for dialysis that became a rate limiting factor, not the ventilators. And so while you all focus on the lungs, it turned out to be the kidneys. I didn't see that much liver stuff. I don't know if Jay, I didn't see too many people in liver failure, but we saw LFT elevation. Yeah. But I think the neurological manifestations are going to be something that's going to trail, and we're probably going to see, I would say, the numbers are going to be pretty significant. Probably 30, 40, 50% of patients have some and probably very severe neurological manifestations in a fair number of patients.
Actually, the group from Wuhan published their neurological experience last week, and it demonstrated 36% of neurological manifestations in the patients with mostly with severe disease. In the ones that had severe disease, it was up to 4 or 5% of neurological manifestations. And they also documented that many of these patients, their first symptom was something related to a neurological symptom, not necessarily the typical fever and cough. But those were the ones that did very poorly clinically.
I mean, what's so interesting is that the disease is asymptomatic in a huge percent. It doesn't occur in kids. Most people get it and are symptomatic or mild. They just have a cough and a fever and they get over it. Then you have another group of patients that comes to the hospital and goes home. But on the other hand, you just annihilate some people. It just basically affects, multiple organ system failure basically. And there's a lot to learn.
There has been documentation of more than 30 types of mutations of the virus. So these will obviously make it more challenging for us to find one simple way of managing all of the patients. Having said that, it is where we are right now. It is now we need to do better with testing, do not only for people coming to the hospital, but throughout the nation and the world. We need to be able to test patients easily, fast, for the virus and for antibodies, in order for us to be able to go to the streets and freely and not be concerned about that terrible outcome that happens in a minority of people, but that ends up in death in a significant percentage of the population. We haven't received them. Actually, we have one more question here. From what you know about COVID-19 right now, will this become similar to a seasonal flu and we should now expect this every year? Dr. Langer?
Yeah, I mean, flu is a deadly disease too. It's not as dramatic because we have a fair amount of immunization. There's probably crossover from the previous flu exposures and the vaccines that are out there, but we get a vaccine for flu every year for a reason. And herd immunity occurs when you have 60 to 80% of the population immunized. So we don't see these giant spikes in flu because at least 60 to 70% of the population probably has some degree of immunization. I think the reason why this winter, as people are talking about it, is just because of this fact that we do not have nearly herd immunity. There's no way we're going to get close to 60% of the patients have immunity. And this whole concept of R naught, which is the number of patients they tip that the one patient on average affects how many other patients. It's the R naught is the R with a 0, R naught. The problem is if you have an R naught greater than about 1.1 to 1.2, you'll get a big spike. If one person can affect more than one person, if say 10 people can affect 12, you see an increase in cases. You've got to keep the R naught less than 1.1. And so the more people that are immune, it's hard to infect people. And so the R naught remains low. The reason why this winter in particular is another concern is because the maximum rate of infection is 20, 30%, probably far less than that. And if we don't have herd immunity, you're going to have the same problem. And so what's going to be important is that the public health service, the CDC, the governments, the state, the federal government are going to have to develop essentially, some sort of very good surveillance to see where the outbreaks are. And then you're going to have to form mini quarantines. My wife said to me, there'll be weather reports telling you where the COVID outbreak is and where people have to shut it down. And it's very likely to happen based statistically. Now, the good news is we're going to have more therapeutics by then, I think. If this Pepsi stuff works out and remdesivir, like you mentioned, and, some other drug trials, even before the vaccine, I would imagine it's not going to be quite as dramatic of, hospitals losing their oxygen from all the ventilators and an overwhelming number of people in ICUs. But, this again demonstrates the importance of good public health and a plan and a plan for it, which hopefully we'll be smart enough to do this time. But yes, it's likely to be probably worse this year than it will the following winter. And from what I understand, I may be wrong, but flu is a much more dynamic virus. It changes every year. The changes in COVID are on the genome level. You can measure where each one comes from, but the actual infectious portion is relatively stable. So if they do come with the vaccine as opposed to H1N1 or H1N2, all these different flus, that the vaccine ought to work, for the foreseeable future. The problem with the vaccines, it's probably going to need a boost, to increase your gamma globulins and IgM. And so, we may be in a situation very similar to flu. We're getting a COVID vaccine, every fall, just like we're getting the flu vaccines. But there is obviously concern. It probably will become somewhat seasonal, and hopefully it goes away this summer for a period of time.
And I think as a nation, socially, we've changed quite a bit. There's probably going to be some new normal in terms of how we interact interpersonally. I mean, it may not be 6 feet of social distance, but I think we probably won't be as close as we used to be. And, I think our hygiene is probably better. We may not be shaking as many hands. And so, when the models predict a second peak, that peak is much worse if we eliminate social distancing, all measures of social distancing. So I think we're probably going to have to, even once the economy opens up and businesses start working again, we're still going to have some measure of social distancing to reduce the likelihood of a second peak and seasonality to this thing.
And for the people listening, we will be expanding on these topics in a major international symposium that we're hosting June 5th. That's a Friday. It will be from 7:30 in the morning to 2:30 p.m. And we will be have panelists from Wuhan, China, from Hong Kong, Germany, and New York City, discussing all these topics from diagnosis to treatment of COVID in the acute setting in the intensive care unit, emergency medical services and paramedics, emergency rooms, how the hospitals are handling this, how neurosurgeons are handling these, the different presentations of COVID in the brain, and as well as the global economic impact and how the different health systems are adapting to the new world and the new reality. There's another, okay, great. Where will you post the info? Zoom. This will be out in approximately a week or so. And obviously we will let everybody know how to register for this conference. If there are no more questions, anything else, Dr. Ellis, Dr. Langer, you want to add?
We're good. Great job.
Okay.
Same time next week.
Same time next week. That's it. See you guys.
All right. Bye.
Have a good day. Bye.
Bye.